Hello. Hi,
Good
Erin.
good afternoon, Dr. Schuster. You beat me to it. It's not quite 2 o'clock. We're still clearing out the waiting room, so we'll give it
Great.
just a moment.
All
How
right.
are you?
I'm fine, thank you. I'm glad to be back, even though it's cold and I left 63 degrees out in Arizona, so a bit of a shock to the system.
I bet.
And I see Valerie is on. I hope, do we have some of our voting members? Have you seen them come?
I've got
Mary, how
Steve
about
and
this
Mary
on?
are on. Oh, there she is.
Steve and Mary are on, you said?
Yes, ma'am.
Okay.
And Val's also on, but you saw her.
Yes,
And as soon as the waiting room clears, it fills right back up. So
okay.
I did want to make a request if Jordan might be able to move up a little bit on the agenda. She has to drop for another call.
And is that on the unwindings?
Yes, I believe that's the
Yes,
updates on that.
that would be the unwinding status and recertifications updates, if that's
Okay.
okay with everybody.
Yes, we've kind of moved things around a little bit on the agenda from when we first scheduled till now. Yeah, why don't we move you up, Jordan, after we hear from Victoria Smith and from Myers and Stauffer? Or would it be better to move you up further than that?
I can wait until after you discuss with them, that's fine.
Okay, thank you. And we'll see what our timing looks like. I don't know how long those presentations are going to be, but we can move you up further if need be.
TJ is coming in and joining us.
Good. So,
The waiting room is clear, so I will turn it over to you, Dr. Schuster.
okay, thank you, Erin, and good afternoon on this very cold January 22nd. And I appreciate your flexibility and our need to reschedule the meeting from the 9th. So welcome to the Behavioral Health TAC meeting, formerly scheduled for January 9th and now being held on January 22nd. Let's see. Val, you want to greet folks, please, as one of our voting members?
Yes, I'm Valerie Mudd, and I represent folks living with a mental illness like myself.
Thank you, Val. And Mary?
Mary Haas, representing individuals with brain injuries.
Thank you very much. And Steve?
Steve Shannon with the CARP Association of Mental Health Centers.
Great. And TJ?
TJ Litific, Nami, Kentucky.
Great, thank you. Is Misty Agneon?
I don't see her on yet.
Okay, and Tara Hyde?
I don't see her yet either.
Okay. Well, we'll go on. We've got a quorum, so we're constituted to do business, as they say. So let me get a motion from one of our voting members to approve the minutes. Actually, the court reporting of the November 14th Behavioral Health Act meeting, please.
I make a motion for the November 14th.
Thank you. And a second, please.
Second, Val.
Val, okay. Any additions, corrections, omissions, revisions? All right, all those in favor of approving the minutes then signify by saying aye.
Aye.
And
Aye.
opposed? Thank you, opposed? And abstentions, great. We just got the response from DMS to the behavioral health TAC recommendations that were made back in November, and it is a lengthy reply. Hopefully you all got it on the email. Erin sent it to the voting members, and then I sent it also to the people on my email list that attend these meetings. So I don't know how much time we want. I have not had time, quite frankly, to go through and look at this. It's quite lengthy. I don't know that we've ever gotten, well, we had several recommendations, but this is much more detailed. Anybody?
Sheila, this is Barry.
Yeah,
I reviewed it and I mean, it pretty much kind of validates some of our concerns, but it doesn't really put a lot of, I guess, direct directions to how are we going to accomplish this. I think Medicaid's saying that it's under the purview of doing what we're asking, but how do we get that to be a little bit more, have a little more bite to it?
Yeah, Sheila, this is Steve Shannon. I agree with Barry. I mean, there's some affirmations of valid point of concern, but it really doesn't seem, I don't know if we go back with a recommendation, if we review it in detail, come back again, it just, the audit questions are responded to. I just don't know if we get, what happens next.
okay.
Does that seem fair, Barry?
I think same thing.
Yep.
Yeah, okay.
This is Mary Haas. I did not get to read it. I did a cursory review and I would have to go with Barry and Steve and say, I just don't think there was a whole lot of meat to it. I mean, they were answered, but I think we're going to have to go more in depth to say exactly, what it is. But again, and I didn't give it a full review, so I just want to give that. But on a cursory review, I just think there was much there.
And Michelle has in the chat, it seems like the responses were directed to prepayment reviews and not the other audits. So obviously we still have a lot of questions about audits. The parallel thing that has come up since we met in November and since we set this agenda, as some of you know, Secretary Friedlander has sent out a letter asking for input on, forget what the exact words were, Steve, essentially.
Prior auth.
Yeah, restarting prior auth. And we, I think in this TAC have long felt that the audits were in large measure a response to not having prior auths. What I'd like to do is to make sure that everybody has these, and let's review them in detail between now and the next meeting. Let's also see what's happening on the kind of parallel track with the whole discussion about resuming prior auths, because I think that will have an impact on the number and extent of the audits, or at least that's the feeling I've had from these discussions over the last 3 BHTAC meetings. So if does that make sense, Steve and Mary?
Yes. It's a lot of information to really develop a strategy around in 3 hours.
Yeah.
I appreciate the response. I just think we need to spend more time understanding it and discussing it.
Sheila,
I agree. I need more time.
Yeah. Bart?
Yeah, just a quick comment on the response. It lays out several of the requirements that are in place on the timelines of the audits. And I think a core question from this group is what happens when those aren't followed? So I think that was kind of my review of it, is there's lots of things that are already in requirements in the contract with MCOs and that Medicaid requires. And I think our concern is great. We appreciate those, but when they're not followed, then what? And I think that's what the lens we need to look at, and what is the corresponding accountability when those timelines are not followed? Because our experience hearing from the providers is that oftentimes they're not, and the requirements are not followed. But then what's the recourse?
Yes, that's a good point, Bart, and I will make note of that. I appreciate that.
Sheila, at least
Thank you.
I'm glad that they did respond and they did validate some of the stuff. So it does give us a little leverage when we want to go to the MCOs and DMS and say, we're being unjustly done.
Yeah. So kind of, it's been worth all those sometimes lengthy and occasionally heated discussions we've had in the BH-TAC meetings, I guess, starting in July, September, November. So I appreciate that, Barry, as well. So that's the direction that we will take at this point. Thank you all. And I will get back and send an email back to Commissioner Lee. She's on vacation right now, but I will send her an email and tell her that that we appreciate the length and the input, and we will be getting back with them for next steps.
Yeah, I kind of feel like we got the vibe from the few of the MCOs saying, well, we're going to do the audits because y'all didn't want to do the
Prior auths.
prior auths. Yeah. So
Yeah.
this is what you get. That's what it kind of felt like to me.
Well, that certainly was kind of the tone from time to time in those discussions, Val. I appreciate that. I have a grid that I will send out of the 2025 BH-TAC and MAC meetings, and I appreciate the change of this one, but the BH-TAC meetings will be on the second Thursday of each month, and that 2 to 4 time frame. We used to kind of shift when they were in session or not in session, but the 2 to 4 time frame works for our voting members. And then the MAC meeting, so that's March 14th, May 8th, July 10th, September 11th, and November 13th. And then the MAC.
Is it March 13th or 14th? Because you've got on the schedule the 13th.
It'd be the 13th.
Yeah.
Oh, I didn't.
Okay, just want to double check.
Friday.
Yeah, I wanted to double check that.
Yeah, we don't want to do Friday. Thank you. So I'll correct that before I send it out. The MAC meetings are on the 4th Thursday, except in November because of Thanksgiving. So January 23rd, March 27th, May 22nd, July 24th, September 25th, and then November 20th. And again, 9:30 a.m. to 12:30 p.m. So we will be meeting, the MAC will be meeting tomorrow morning at 9:30. And again, I will send that corrected version out, and Aaron will get it out to you all, and I'll send it to my email list. So next on the agenda is Victoria with us, Victoria Smith.
Dr. Schuster, she's out today, but I wanted to discuss that just a second. And I know Commissioner Lee is not available, and I don't believe Veronica's on, so I'll do my best to try to explain about the rate study. I'm not sure if you're aware, but there's a much larger request for a like a full rate study initiative that is required and has to be completed for LRC. And so they're going to embed phase 2's multi-state work into that work for the LRC. So currently right now, Medicaid and others are being tasked to gather data and information to submit over to the LRC identified staff. So I know that's not what you wanted to hear, but that's where we are. It's going to be embedded into a much larger study that'll be completed by LRC staff.
And that request is part of what was in the budget bill, as I recall.
Yes.
They put some money aside and created an office over there.
Yeah. So we're currently, they've requested lots of reports from us, and Medicaid has been working on getting those reports turned around quickly. It sounded like to me the initiative was to go fairly quickly, though. It's not going to be one of those that lags on for years and years. I think that they've directed staff to complete their task fairly soon. I don't have a timeline for you. I'm sorry.
Okay, so I guess we still did not get from Victoria the final piece of phase one. And that should not be,
Final of phase one.
Yeah.
I'll double check on that one. I know phase two is what I'm talking about, right?
yes, right. And I understand that because that was
Yeah.
a new study and it was going to go in a different direction. And the legislators control the purse strings and had asked, put that in there. So, but we should be getting a final report from her, Leslie, on the completion of phase one.
Okay, I'll double check on that.
Yeah, thank you.
And again, I don't know if that stops us then on phase 1, 2 also, but I'll follow up. But I knew for sure it was phase 2.
I don't know that I'd have to go back and look. And Bart, you may remember there were a couple of kind of hanging pieces, or Michelle may remember that we got back with Victoria about to kind of wrap up on phase one.
Yes, Dr. Schuster, it was really accurately completing the grid. There was a grid on there for each code.
Yeah.
And phase one, it was the two things, I think the two main things to finish out phase one was to add in Missouri and Illinois for comparison for those states,
Right.
for those border states. And the other piece was there were several instances in the grid where the draft report had said that they couldn't find the comparable code in another state. And we had folks from, I know Michelle with the Children's Alliance provided a lot of that links to those links to those rates in other states. And we were provided some with ABA advocates as well, but those were the two pieces that include the two states and to complete the grid where you can, because we felt like those where she didn't find those, we sent the resources to where she could find those and to complete, because there was a lot of X's, if you remember the grid, that said it wasn't available, but in reality it is. And so finishing phase one, I think, was just those two things.
Okay, so give me some time to ask. And again, Commissioner Lee is out too, and I know she was actually going to speak on that today. I just wanted to give you what information I had.
Okay.
Yeah,
Thank
I
you, Leslie.
appreciate that, Leslie. I do think that those completion pieces on phase one were communicated back before the November meeting. So she's had that in her kind of work thing before. Maybe this push came from the LRC, I guess is what I'm saying. It's possible that she was able to get those pieces finished.
Okay, I'll double check.
Thank you very much. I appreciate that. Let's go on, and Jordan had asked to be moved up on the agenda. And before we get into the Myers and Stauffer, are you all right with that, Leslie?
Absolutely.
Okay.
We're good today.
All right. Jordan, would you go on and give us the information? This is typically what Veronica Judy Cecil gives us on unwinding and recertifications. And I think you should be able to share your screen if you have something to, yeah, there we go. Thank you.
Okay, so you all see in the PowerPoint Medicaid renewals update?
Yes.
Okay, thank you. So this is our Medicaid enrollment trend graph. It's really good to see that our enrollment's kind of leveling off after the unwinding, after we had ultimately a drop in enrollment after the unwinding rules were rolled back as far as maintenance of effort. It's kind of stabilizing around 1,450,000 current enrollees.
And that's been the last couple of months, or the last year almost.
Yeah, so the
last
dates
couple
are
of
down
months.
here.
Yeah.
Yeah.
Yeah, certainly since July of 2024. It's really been along that line. Okay, thank you very much. That's good.
Yeah. So regular annual renewals for cases following the public health emergency resumed in April 2024. We do have the flexibilities from the public health emergency in place through June 2025. There was information from CMS that outlined options to make some of the flexibilities permanent. These are still under consideration. And we're not sure with the change in, leadership over at CMS if that'll impact any of the recent informational bulletins that have come out or not. But we are still considering which ones we would like to make permanent. And then we do have the streamlining Medicaid Children's Health Insurance Program and Basic Health Program application eligibility determination, enrollment, and renewal processes. Final rule, very long name, but basically that is meant to streamline application and enrollment processes, improve retention rates at and between renewals, remove access barriers for children, and overall enhancements to program integrity. We're currently still reviewing to see what updates we need to make based on that final rule from CMS as well. And then we,
Oh, I'm sorry,
Yeah.
Jordan, we
Go
don't
ahead.
know whether those things are going to stay in place or not with the change in administration, right?
correct. Yeah, everything is kind of up in the air right now
Okay.
with the changes. As of right now, we're continuing forward with our, current roadmap for implementation of these things until we hear otherwise.
Okay, thank you.
Yeah, absolutely. And then we do have our CMS monthly and updated reporting that continues post unwinding. So here's some report updates. We have to report the updated renewals after the 90-day processing period. So we just reported September's numbers after the 90-day processing period. So over here on the left-hand side were the original report, and on the right-hand side is our updated monthly report, just showing that we had one pending renewal that was processed and added to the terminations column. It appears they were not eligible, so they were terminated.
Their eligibility was terminated.
Yes, if you look over here, we had Medicaid terminations of 1,234 with one pending. Once that was processed, we had an additional Medicaid termination listed, so they were not eligible any longer for Medicaid. This is the slide about renewals and reinstatements. So we have a reinstatement period of 90 days where individuals can respond and provide requested information and have their coverage reinstated back to their termination date. So months that are still within the 90-day window are still processing reinstatements, and these numbers are included below. You'll see the most recent 90-day reconsideration period ended in December. We had 181 reinstated as of January 10th, back to December when they lost coverage.
So the numbers on the far right, that little box are reinstatements. For instance, 801 out of the 6798 that have been extended for October.
Correct. So October would have been their original renewal month, but they didn't respond or return information. They've come back into the Medicaid program and had their eligibility reinstated. So that's the total over here, reinstatements. So 801 individuals have been reinstated back to October because they responded within the 90 days to be reinstated. Subsequently, it's 750 for November and 181 so far for December.
And they have 90 days.
Yes, that's correct.
Oh, okay, thank you.
Yeah, absolutely. Additional resources, as always, are included on our PHE website. We continue to post new information and updates regarding renewals, even though we're kind of post unwinding period, at the medicaidunwinding.ky.gov website. As always, the message out notice here at the bottom still applies. We still have people who aren't responding to renewals or maybe don't know that they need to complete a renewal. We have informational flyers available in English and Spanish for anybody who wants that information to be able to pass out to members. And that's it for me. Thank you all.
We lost Dr. Schuster.
I was just getting ready to ask if we lost her.
Let's give her just a minute,
Yeah,
Aaron.
makes sense.
I think she dropped, so she may need to log back in. So
All right, she says she got kicked off.
Well, I'm
Coming
back
in.
on now.
Yeah.
Thank you. So sorry about that. Did we lose Jordan or did you just lose me?
We lost you. She was done,
We
I think.
just lost you. I'm so
Oh,
sorry.
okay. All right. Well, I'm fine. I thought we had lost you and then I guess I got kicked off. So much for the internet. Jordan, would you send your PowerPoint to Erin, please? Because she'll
Absolutely.
send
Yeah,
it
she
out.
should have copies of it
Okay.
to disseminate out. Yep.
All right. I asked some questions as we went along. Were there any other questions to ask Jordan about the information on the unwinding and recertifications? Okay, thank you so much, Jordan. Appreciate it.
No problem. Thank you all.
And Dr. Hoffman, we'll go back to you and whoever's with you from Myers and Stauffer to give us a summary of Kentucky's statewide needs assessment, please.
Is that next on the agenda, Sheila? I've just asked.
Yeah.
Okay. Okay, so I've got Amy, Karen with me. And if she-
Leslie, does
Yes.
someone need to screen share so I can make them
Amy,
a
I
co-host?
did. I just sent a request. Thank you. Sorry, I should have done that earlier, Erin. I saw the button and I thought I could.
I should have said something too.
No problem. There you go.
So just to start out, Dr. Schuster, if you remember, I've sent you some emails over the last couple of weeks. We have made some minor changes just because we've had a little bit more time to look at it. And really it was just, I think the modifications are more about just having clearer communication kind of thing. So we're going to go over today the statewide behavioral health needs assessment. And we are very excited about going over that with you today. So I'm just some background. The Behavioral Health Needs Assessment was initiated based on the original guidelines and the guidance that was from the 2023 U.S. Department of Health and Human Services criteria for our CCBHC providers here in Kentucky, and that's our certified behavioral health clinics and related to their certification. It recommended that states develop a statewide behavioral health needs assessment to identify community needs and to determine program capacity to address the needs of the population that are being served across Kentucky. So as you may know, we're currently evaluating on how we could expand the demonstration, the CCBHC demonstration, to additional providers. So it is very important for us to follow all the guidelines that are set for us. I'd also just like to note that the assessment represents a snapshot in time. I know you all get tired of us saying that sometimes, but this was definitely a snapshot in time and presents information that was available during the assessment process. There's been a lot of work that's went on, and I'd like to give a big shout out to everybody that's helped with that. At Medicaid and Myers and Stauffer, our contractor, as well as our Department of Behavioral Health. Lots of good work is going on across the state. And we anticipate this is actually, if you have noticed, Dr. Schuster, when I was talking to you earlier, we consider it a draft. It's a living document, and that we want to continue to add to this living document as this initiative goes forward or progresses. So this is the PowerPoint presentation, and I will have Erin to send it to you as soon as this presentation is over. Next slide, Amy. just to go over the purpose of what will be discussed this today is the purpose of the needs assessment and the methods used to complete it. What we found in our research, what we discovered in our research and through our partnership engagement and our partner-driven and best practice recommendations and opportunity. And then we'll, of course, go through some takeaways and potential next steps. Next slide, Amy. So this is getting started with the introduction, and I'm going to turn this over to Amy, who was a big help to us in completing this needs assessment, and we'll go over the introduction, the purpose, and the needs assessment and our approach. So Amy, I'm going to turn this over to you now.
Thank you, Dr. Hoffman. Thanks, y'all. So you can see my screen, you can hear me, right?
Yes.
Okay, great. Thank you. So the goals of the behavioral health needs assessment really are to identify, understand behavioral health needs and gaps, which I think you all know in the current system of care. The findings can be used to inform policy and program development, improve access and availability of proper services, and enhance outcomes and promote equity in the behavioral health system of care. I'm going to have to switch. There we go. Okay. One of the most important aspects of our methodology was establishing the Behavioral Health Collaborative Work Group, which met regularly throughout the project to guide all aspects of the execution of the behavioral health needs assessment. The group included leaders from DMS and the Department for Behavioral Health and Developmental and Intellectual Disabilities, and we're so grateful for their time in providing oversight and decision-making. And this really promoted a sense of transparency and collaboration from the start of the project. Within the collaborative, with the collaborative work group, we determined a specific set of research questions that were then used to guide the various inputs that you see here, which included a review and catalog of documentation to map available resources, robust research of population health needs and best practices, partner engagement, which we use to collect quantitative data from behavioral health and primary care providers through a survey, and qualitative data through interviews, focus groups, and questionnaires. We conducted an analysis of available state and national data as well, such as from like Medicaid claims, MMIS, Kentucky Hospital Association, SAMHSA, I think CDC, to identify some trends and disparities. So just some stats on the methodology. We reviewed over 120 state documents and literature sources. We analyzed 9 key public and state data sources to understand the need. We created 12 separate in-depth population profiles, which were determined by the Behavioral Health Collaborative Work Group. We engaged with 63 individuals representing 53 organizations across the landscape, which included behavioral health providers, primary care providers, advocacy groups with individuals with lived experience, community supports providers, health plans, associations, and of course, state agencies. And finally, we received 351 completed responses to the behavioral health and primary care survey. So behavioral health statistics can help illustrate the scope of the needs, and I think I'm gonna go through these really quickly so we can get into some of the other, because I think you all are probably familiar with a lot of these stats already. Kentucky residents tend to have higher rates of depressive disorders and mentally unhealthy days throughout the nation. Suicide is a leading cause of death. Youth are disproportionately affected by behavioral health care conditions. And though the overdose rate has been decreasing, Kentucky still ranks 7th in the nation. When looking at different populations, again, youth, when looking at a measure, a composite measure, Kentucky ranked 36th for youth with high rates of mental illness against access to care. But that wasn't really seen in that same study for adults. 75% of youth with major depression did not receive care compared to the national average of about 60%. Veterans have higher rates of suicide than national averages. Almost 60% of youth identifying as transgender seriously considered suicide, and over 12% of older adults have frequent mental distress. So looking at the Medicaid population specifically, over half reported experiencing 1 to 13 days of poor mental health over a month period. Regionally, Eastern Kentucky had the highest proportion of, oh, that's okay, Hannah. Oops. Regionally, Eastern Kentucky had the highest proportion of adults reporting poor mental health, specifically in regions 8, 9, 10, 12, and 13, all reporting over 20%. Eastern Kentucky also had the highest rates of behavioral health related emergency department visits in 2023. Southeastern Kentucky and Appalachia have the highest needs related to the safety net. So there's more lower income individuals with higher rates of little to no insurance coverage, rural geography, and of course, transportation challenges and English proficiency. And looking at overdose, I know I'm going through these fast, looking at overdose death rates across the state, Breathitt, Owsley, Lee, Estill, Powell, and Menifee were all among the highest, and Carlisle and Hickman counties had the highest suicide rates in the state. So now we start getting into Medicaid claims data. So looking at specific provider types to look at service utilization across what was categorized as inpatient hospitalization, residential treatment, partial hospitalization, and outpatient services. And the provider types under those categories was determined in collaboration with the Behavioral Health Collaborative. So looking at the last 5 years, there's been a steady growth in lower intensity services, partial hospitalization, and outpatient services, although there's still significant use of emergency services, especially for substance-related diagnoses in Eastern Kentucky. There's been some growth in inpatient services, but not as substantial as the lower intensity services, and residential services has been somewhat consistent. So while access to lower intensity settings has expanded for Medicaid members, utilization of behavioral health services has risen overall, and we haven't seen any substantial increase in utilization of higher intensity settings. Next, we looked at the number of providers fitting the definition of each type under, again, inpatient hospitalization, residential treatment, partial hospitalization, and outpatient services. There's been 29% decrease in outpatient providers. Let me see. Yeah, 29% decrease in outpatient providers during the 5 years we reviewed. But again, as we know, behavioral health needs continue to rise. And there hasn't been nearly the same amount of growth in higher intensity providers. And the number of residential treatment providers remains consistent. And we did not have data for partial hospitalization.
Amy,
Yeah.
when you talk about providers, are you talking about licensed mental health, behavioral health providers? Are you talking about providers that also include peer support specialists and
yeah, so I should, yeah, and we can add this to the slide. So it doesn't include like peer support, so I can just run through, and again, it's not on the slide, but I can include it in the version that we can send around so you have it for easy reference. Inpatient hospitalization is psychiatric hospital, psychiatric distinct part unit, the DPUs, rehabilitation DPU. Residential treatment and short-term services include psychiatric residential treatment facilities level 1 and 2, residential crisis stabilization unit, and intermediate care facility for individuals with IDD. Partial hospitalization includes chemical dependency treatment center, and outpatient includes CMHC, BHSO, CCBHC, and the Behavioral Health Multi-Specialty Group.
And again, my question is, even within the CMHCs or the BHSOs or the partial or whatever, are most of the providers you're talking about licensed professionals, or do they also include lower level, if you will, peer supports and ABA technicians and so forth? That's what I'm trying to get at.
I wonder if Martin, are you from Myers and Stauffer on? Because it may be a question I have to take back to the analysts.
Yes, I'm sorry. Can you repeat the question? I
Yeah,
didn't
my
quite get the
question,
provider
I'm
types.
trying to get down to the provider level, not the facility or the setting. And I want to know if we're talking about licensed, individually licensed mental health SUD providers. In other words, they have a statute, they have a board, they have criteria and so forth. Or when you talk about providers, are you also including peer support specialists and technicians and those kinds of things?
It would be the providers as they're registered in this context with Medicaid. So if they have different provider numbers, they would be counted differently, but they wouldn't be. That would just be if they billed, say, under another provider, they would be counted together.
Well, the reason it's so important to me is that we've had a million discussions, hours of discussion here in the BH TAC about things like peer support specialists and those services, which are qualitatively different than a clinical psychotherapy session. That's what I'm trying to get at.
Mm-hmm.
And I'm trying to figure out what your data really tells us.
Yeah, I am not sure about the specifics of that. We might have to look into that further.
Mm-hmm.
Well, I would encourage you to do that because it is a really important question. So when we talk about provider workforce, we can't just use provider to mean anybody who ever gets a Medicaid payment because the range is great. And we're trying to concentrate on, because we really don't have good data on how many licensed mental health and SUD providers we actually have that are functioning in this state, because the licensure boards don't have that information. And that's what I'm trying to get at, because you all have a wealth of information here. I'm just trying to get at some issues that keep coming up.
Yeah.
So,
We can take it back. I mean, this would be MMIS data, right, Martin?
That's correct. Yes.
Yeah. I know. Yeah. And to get at and this is not, we've run into this very question with work in other states too, and trying to understand from a licensing perspective what the landscape is. But we'll take it back and kind of, look through it again, but
it's difficult. We ran into this with Victoria on the rate study when she was trying to compare Kentucky with other states, and we were trying to get at how are you defining who these providers are. So it really is an important question, I think.
Yeah, it gets to, no, I'm sorry, go ahead.
Well, just that, it's a workforce issue, and there's, a big group that's working on workforce, and I always am concerned about whose work are we looking at, and who's doing what services, because not everybody can do all services. And the MCOs were complaining about how much they were spending on services that they did not consider to be clinical services, meaning they were not delivered by a licensed clinician. And so, I'm trying to get at that, and you all have this data. My other question, because Leslie started out with this is a snapshot in time. I didn't hear from you or see anything about what's the time frame during which you were conducting the study and gathering this information.
I'm sorry. Yes, good question. So this started late. You might have worked with Alex Ferrugia. So this started late October of 23. And we just wrapped up a couple of months ago. So I'd say like the data pulls would have been early 2024 for the data that you're seeing here. And sorry, Martin, and this data goes the last 5 years, 2019, I think, or?
Yeah, we had that available for some things, but for this display, it's 2023.
For this one, yeah, sorry, yeah.
Okay. Let me ask, Shannon Stiglitz has her hand up. Shannon? No. Okay, we'll come back to her.
Sheila,
Thank
would it help the process if we delineated those providers specifically? I mean, have a list for peer support, a community support associate, target case manager, associate level independent practitioners.
Yeah, I mean, we could provide that to you. I don't know how you get the data and what categories, MMIS gives it to you in.
Well, that's
All those categories are defined in the fee schedule. And you
Yeah.
have to have modifiers that delineate who's delivering the service, whether it's a licensed person or associate or what level. So I think that's should be identified. I mean, it's defined within the fee schedule
This Stuart on a WellCare,
already,
jump in real quick,
right?
sorry. So the individual, the licensed clinicians, they'll be credentialed and affiliated with the MCOs, but the ones that like Dr. Schuster's talking about, the peer support specialists and others, those are not individually captured in any way, the ones like that. So I'm thinking that would be, I don't know that would be, I don't think it'd be in the MMIS, in other words. They're not individually affiliated,
Right.
credentialed, linked,
The
enrolled.
service would be there, right, Stuart?
Right. You could see the service, the modifier, you know it was done by somebody who's a peer support specialist, but I don't think we would have, the actual numbers of peer support specialists, et cetera, paraprofessionals, basically.
Yeah, this gets into the limitations of the state data that we have that access to.
Yeah. Shannon, are you ready now? You've had your hand
So
up.
I couldn't, for some reason, open Teams instead of trying to get off mute on Zoom. So I apologize. My question really goes to the data, and can you add additional information? For example, regions are very different in size, number of providers, especially across these various categories. So for example, if you look at North Key, outpatient, there are 3 claims per provider type. But like you look at inpatient, there are 30 claims per provider type. Well, and I know that this is unrealistic, but okay, you might only have one provider that meets. How many providers fit within these categories, or the number of claims per provider, in my opinion, don't really, it doesn't tell you anything. Because for example, you're going to have very rural regions and you're going to have very urban regions, and I think it's, common sense dictates how those claims might vary, but it'd be very helpful, in my opinion. I guess I don't know what, in some respects, the point of this slide is without additional information. I don't know if you can really glean anything. And I'm new to the behavioral health world, so Dr. Schuster can tell me. I'm not new to the Medicaid world, but I'm new to the behavioral health care world, so she can tell me I'm crazy. But that's my thought, if you could add some additional data.
I just have a question. Does this also include like the non-licensed people that provide counseling services at the comprehensive care centers, like the people that are in bachelor's level who are providing counseling services that don't even have a license or a master's degree?
The mental health associates, is that what you're asking
Yeah.
about?
Uh-huh.
Mm-hmm.
Martin, I wouldn't think that it would, because this is again at the facility level, right? So it's
Right.
But-
It wouldn't count them as separate providers.
Thank
Right.
you.
Now, when it says like Region 1, 4 Rivers, is that 4 Rivers data, or is that data from those counties in the region?
That data is identified by the county in the region, so
Okay.
it's not from
So
the
right.
organization.
So when we see North Key with 30 inpatient hospitalization, that does it per 1,000 members. That's a reflection of the 8 counties in that region. Right?
Mhm.
Yes.
And I guess in my mind, Steve, that goes to without knowing the number of providers, without knowing the even inpatient hospitalization, the provider types, because you could have O2, you could have O1. Um, I don't know that you're getting a clear picture of utilization. Or let me say it differently, where are services needed in regions and in communities?
Yeah, these numbers don't make any sense to me because some of the most heavily populated,
Well, the 3
largest have the smallest numbers of outpatient. So what is that outpatient telling us? 7 counties in North Key.
yeah.
I guess
And
that's
even New
only,
Vista is
yeah.
full.
And New Vista is real low. I mean, and then you've got Kentucky River, which is very rural in eastern Kentucky with a tremendous number. I guess I don't understand what the numbers reflect.
So I wonder, because so there's a detailed document that goes with this that part of me thinks may be helpful. I know that Dr. Hoffman is signing off on those, and it may be helpful to see all of this in the greater context. We were kind of picking some pieces out of it to show you all to try to, present prior to getting all of the documents, and there may be, all of the context in there. But there's also limitations in the data that we have, right? I mean, I think getting to the full denominator of providers, especially outside of Medicaid, is the challenge, right? I mean, and this is really, this data particularly has limitations. But again, maybe in the full context of the document in its entirety, again, may help. And this is also a starting point. I think there's other workforce initiatives and other things where other data can be layered on to this as well. But this is again just a snapshot of the Medicaid data that we had access to.
Yeah.
Can I ask a question? This is Chirag. I'm sorry to interrupt. I had a quick question. Amy, this is fantastic data. I totally understand the limitations of gathering data in the Medicaid world. So kudos. Will you guys be releasing recommendations with your data, or is just releasing data? Because I think I would have consternation if you had recommendations being released with the data knowing its limitations, right? Because then it could be misconstrued.
Yeah, so we'll get to some of the recommendations, and it's important to note with the recommendations and with that the part that we'll get into is it's partner driven. So we had a lot of conversations with community members and other providers, and of course across state agencies. So you'll find that the recommendations, and again, these are a starting point. It's kind of a place from which to build and to pick apart and analyze and figure out, okay, what do we need to do some further analysis on? What do we need to further drill into to then really sort of build this out? So I wouldn't say, yeah, recommendations based on this data only. No, there's some additional kind of inferences, but that's really to generate more research questions. What other data can we, again, layer in to try to expand the story here? But to say that we made direct recommendations just on this data alone, no.
Okay, perfect.
Yeah.
I appreciate that. Thanks so much.
Sure. Yeah, thank you.
Yeah, and just as another concern, 7 counties, North Key and New Vista, are approximately close to 50% of the state population. 45 to 50%. Comprehend is about 1.5% of the state population. Comprehend comes in at 498 claims per 1,000 members, and the other 3, close to half, coming in at 67. I mean, it on the surface, it doesn't seem to make sense to me if it's done by region. Knowing what I know about the regions and the population, it's really hard for me to get to the the Region 6, Region 7, and Region 15 compared to what is the smallest region by population?
Steve, that's a great point. This is Jody Allen, Behavioral Health Specialist with DMS. And I just wanted to mention that we recently did an assessment of availability of providers across the state as a piece of our SMI 1115 application to CMS. And I think, honestly, we broke ours down by MCO region. And I think if you cross-reference this with that, it would probably make a lot more sense. So I didn't know, Amy, if you all had access to that or if anyone had shared that with you, but I do think that it could be helpful in looking at this again and maybe considering some options for breaking this out a little more.
Thank you. Yeah, I mean, I did not see it, so yeah.
We appreciate your work, Amy. We're not, we're just
No,
gonna make sure it
this
makes
is
sense.
well. Let me say, and I don't know if we talked about this at the beginning, but it's meant to be a living document. This is meant to be, again, a starting point to be picked apart and to say, exactly what Jody, it's good to hear from you, but exactly what Jody had mentioned. Wait, we also did this. If we try to layer this and kind of look at it that way, we can maybe piece it together or understand the story a little better. So absolutely. I mean, this is, again, it's a place to start. And it's a place to build from and add to over time. So this is
right. And I would say honestly, Steve, as far as your question, one of the things that we saw for sure, there are so many other types of providers in the urban areas. And so in the more rural areas, obviously the CMHCs are covering a lot more ground. So and we actually saw that in our data too.
But this is, again, if I understand it correctly, this isn't
CMHC. It's all
this isn't the CMHC. This is the geographical region.
Right. Right. And breaking it down into the 8 MCO regions, it captures it differently. So yeah.
So there was a question in the chat, Jody, about whether the data that you gathered is available.
And it's not, it is actually, so I'll have to double check on that. I think that we can share more internally because it's not a public document. So I'll have to check on that, Sheila, but I'll take that back. Okay.
Yeah.
Jody, is this something that is part of that what's lying at CMS for approval?
It was actually just something that we submitted as part of our application, but it's not in the public documents that they put out.
Usually we wait till we get back and forth with CMS in case they say that there's something wrong or we need to correct something before we send those documents out to the public, but they eventually will be available.
Yes, but I can double check. Okay, Dr. Schuster.
Like she's frozen. Yeah, we'll pass that on.
Okay.
Sonia Carrico, you have a question?
Yeah, I did. I've had some of the same questions everybody else did, but I'm thinking about how to interpret this information moving forward. And as you already pointed out, Steve, some of our more populated regions have the lowest numbers. So it makes me wonder what the population density is for these regions. So we can see the number of Medicaid members compared to the population, because my mind also starts to assume that in 7 counties, North Key, New Vista, we have fewer people on Medicaid. And I don't know that that's true. But then knowing those things kind of leads me to some other questions about access and who's providing services that would come next.
But with 1,000 claims per 1,000 members, flatten that out. Was that the intent of that, do you think? Either Amy or Sonia?
Yeah, that was the idea with this. But I think to the points made earlier, this is more to show the differences in utilization of the provider types. And like Amy said, these are really facility based. And this might be pointing to that rather than members in 7 counties and North Key going to these types of facilities, they're going to other types. And there is more detail on which types of facilities are included in each of these in the report. So I think this really just points to the utilization of services is quite different between those urban and rural regions.
I think that, oh, sorry. I think that could be in part because of what's available, what's accessible in those areas. If we understood the access points, that may explain why more people use outpatient versus residential in some communities or others.
Right.
Because if it's not available, then those numbers are going to be low and they're going to be higher in the other categories. It doesn't necessarily indicate that that's where patient need is and that we really need to think more about ramping up outpatient services because we see high numbers there. That just means that was what was available at your point in time.
That makes sense. Yeah, Sheila's been kicked off again, so we'll just go ahead. You want to keep going, Amy?
Yeah. No, thank you. Yeah, this is the exercise. So I appreciate the discussion and the questions around this. So thank you. And when
There was a comment about more populated region have lower, where's that comment? Lower density, maybe? Could one interpretation be that the information that more populated regions have a lower density of providers than rural? Quite possibly. I mean, that's a good point, Jared. We've been talking about the impact of rural versus urban areas for years, and that's one of the issues that we quite often discuss. But I don't still get the disparity. I mean, truthfully, single digits for two of the largest. Anyway.
Yeah. Yeah, thank you. And this is, again, it's another potential inquiry. It's another, drill into the data or other data to be able to understand. So, it's a valuable exercise to be able to look at the data and pull it apart like this, right? And be able to ask those very questions.
One provider type be under 110, right? But there's multiple dispensers of clinical care under 110. Is that a possibility in the data, in the outpatient data? Because I do agree, right, Steve, you're 100% right. How is it that North Key or 7 counties has just 4, right? But is that for example, a provider not to be named who's out there dispensing tons of care actually, but under 110 with multiple dispensers of clinical care, i.e., the ones who have been in the newspaper here recently and who are under investigation by the Attorney General, right? So, not to be named, but I'm just trying to figure out, there is all that nuance within the subtext of the data. And then, bad care drowns out good care, right? That's actually a data science phenomenon, right? Fade out, right? And so when you have fade out, one intervention drowns out the other intervention. It's not that it's better or worse. It's just it drowns it out and it creates background noise in the data. And so actually, if you have a lot of outpatient or lower level services, just by default, people don't get higher level services or inpatient care, right? And it's not that there's not enough inpatient care. It's just because there's a drown out phenomenon. And so you'd have to do kind of multimodal regression analysis to figure that out. And I don't know that your data set is structured that way, but since you're nodding your head, Amy, what I'm saying is probably resonating with you. And my fear is that without that level of, kind of, appraisal or scrutiny of the data, you'll have aforementioned non-said providers taking that inference to say, oh, we just need more providers to come to these rural counties, where it's actually the opposite. Like the ARCs of the world will just put more providers out there and run, mills of clinical care. I mean, just as it was
Dr.
alluded.
Patel, we are not going to throw people under the bus. So do not name other providers. Thank you.
I apologize. You can strike that from the record. So just anyways, thought I'd share that there are some limitations to the data. And we can put that on the record though.
Thank you. Dr. Schuster, I know you got kicked off and you're back on. I know you have a lot of other items on your agenda. Are you okay if we continue, or?
Yes, I think we want to see what you've got here. Thank you.
So here we're looking at strictly, and this is SAMHSA data. There's looking at strictly at locations of behavioral health providers. So this is CMHC and non-CMHCs. Now here, when you look at the areas of need, like the Western counties, like we talked about, Hickman, Carlisle, and Union, they have the higher rates of suicide and self-inflicted injury. Central regions, Breathitt, Owsley, Lee, Estill, Powell, Menifee, with high rates of overdose, and Meade and Hancock and McLean with the lower safety net scores. Just again, looking at this data, you're seeing that the providers are a little more geographically sparse. There's a trend that we're seeing here in this data that, again, like we were kind of talking about on the surface, providers are a little more sparse in the rural areas, right? So if you look strictly at this data, BHOs and CMHCs by region, you'll see that 1 to 4 have lower provider to member ratios overall, and there are lower number of providers in region 8. And again, you all will have the detailed report here. And I think these questions, as far as where this data goes next and what we do next with it, those questions that are coming up with this data are going to be really, really helpful. This is really just to get the discussion started.
Can I ask a question on that last slide? You know, I'm sorry, but
no, it's okay. Oopsie. Yeah.
7 counties has 10 CMHCs. Kentucky River has 11.
These would be provider locations, not necessarily.
Well, Four Rivers has more than one location.
Yeah, I think all
I
of
mean,
the
it's either or, and if that's the case, I mean, New Vista, I rent property from New Vista, and they have a location in this area, you know, 100 feet from me, 500 feet from me, and they got one 3 blocks from my house. So I can verify right now the New Vista data is wrong, right? Because I got 2 locations that I can get you to immediately, plus their main office. And communicate in multiple
Dr.
counties.
McCune from 7 counties says 7 counties has more than 10 locations.
Yeah.
I don't know what that number is.
Yeah, that might just be how the data is reported. We can look into that more and see if we can figure out exactly what happened there.
Yeah, that makes sense.
We're only as good as the data, and then this context is so helpful, right? This context is really helpful.
The data and the question.
And the questions, right. Well, right. So again, this is just, it's just, here's what the data sources tell us on the surface. And then all of this context and the layering of all of, you know, the other data sources and what we know on the ground and what you all know is really very helpful to then scrutinize the data in other ways. Great. Okay. So now throughout these next slides, we're going to look specifically at the partner engagement findings. So we did interviews and focus groups, questionnaires, survey. So we gathered all of that information and came up with some key themes. So again, this is high level, and the report itself goes into a lot more of the meat. And again, this is all from partner discussions and partner information. So when we talk about strengths, partners really underscored the state's commitment to improving behavioral health and the continuum through groups such as this one, targeted task forces, committees, councils that are focused on these efforts. Partners also highlighted the impact of CMHCs and various integration models that have been employed in the state. And they were really excited about the CCBHC model and the CCBHC expansion efforts that are upcoming. Medicaid expansion was, of course, also mentioned to increase access to coverage, and partners supported the expansion of the roles of peer support programs, and expanded telehealth coverage in Medicaid. Other interventions were discussed, especially co-response, the co-response grant program, 988 call centers, mobile response for children, and local efforts in crisis call diversion programs. And of course, investments to address the opioid epidemic were discussed quite a bit, namely CORE and Find Out Now resources, bridge clinics, and in-home therapy programs. We were also able to talk through some of the new efforts, the recent efforts around the 1115 waiver and 1959, which increases funding to support justice-involved populations and adults with SMI and SUD. Support Act funded initiatives focused on pregnant women and postpartum women and infants with neonatal opioid exposure and women receiving MAT. The state is also doing a lot, as we talked about, to address behavioral health workforce challenges. The Workforce Innovation Development Collaborative, which is very active. It's a multidisciplinary effort to review, design, and implement and evaluate policies and programs and practices to improve the workforce and retain the workforce. A couple more focused initiatives came up in our discussion. Multi-systemic therapy pilot program that's currently in evaluation. The Kentucky Court of Justice advancing a recovery-oriented system of care model. That's also through a collaborative process to get children to appropriate services and divert from the justice system. Partners also mentioned that as a strength. And partners talked a lot about various health equity initiatives and the health equity focus for the state. This is one of what's the top, I think, of 5 priorities in the CHFS strategic plan. And there are specific initiatives in advancing equity through hiring, procurement, utilization of racial equity tools to evaluate programs and impact, and disaggregating data to uncover disparities in outcomes and to target various campaigns and efforts. Okay, so strengths. Those are, again, high level. There's a lot more in the report, but we're going to get into some of the challenges at a high level. None of these were really surprising, and these are common challenges that are also, other states are facing the same. So as mentioned previously, we had 351 survey respondents, and these are behavioral health and primary care providers. So you'll see there's, over 3/4 of primary care providers and over half of behavioral health providers disagree or strongly disagree that the behavioral health system is meeting the needs of all Kentuckians. And when you look at specific groups that they perceive to the least likely to receive the services that they need, behavioral health providers noted adults 65 or above. Of course, individuals that are not insured or underinsured, and Black African Americans are those that are least likely to receive the supports they need. And primary care providers noted adolescents, ages 13 to 19, and Latino, Hispanic, and of course, again, individuals that are not insured or underinsured as being those that are the least likely to receive what they need. So challenges, reimbursement, and funding was the most widely discussed, namely low rates, reimbursement issues, claims denials, delays, low network coverage, all of which reduce the number of providers participating in Medicaid and with commercial insurances and reduce the availability of services. Lower pay and limited funding, of course, can also limit the necessary community-based programs that can support the behavioral health care system as well. Workforce shortages, it's a known challenge. I know we talked about it a little bit so far, and maybe more challenging in rural areas. Partners talked about specific consequences of that, like, of course, longer wait times, but the overutilization of non-clinical or higher intensity services in the absence of other services that are needed, such as like over-reliance on peer supports or APRNs or other paraprofessionals, which can lead to misdiagnosis if that's what they're doing, or poor management and oversight of treatment. And also can contribute to burnout of these valuable professionals as well. Providers did underscore that participation in managed care as well as commercial insurances with various policies and procedures is an ongoing challenge as well. Gaps in the behavioral health care services that are available, namely housing came up quite a bit and recovery supports. We talked a lot about the need for comprehensive eating disorder treatment facilities and services focused on children and youth, which is a population that is experiencing higher rates of behavioral or rising rates of behavioral health conditions, and that's across the nation. Partners also discussed fragmentation and limited care coordination and collaborative care, right? They said, yeah. I thought there was a question. Citing privacy concerns, lack of training, administrative burdens, lack of data sharing and interoperable systems came up quite a bit as factors that limit care coordination. And talking about health-related social needs, this came up a bit also. While the providers understand the need to assess patients for health-related social needs, many of them said, I can't assess for something that I can't help to address. And we know that Kentucky Find Help Now, for example, may be a resource that's helpful, but it was not something that all of the providers that we spoke to knew about. So sometimes a lot of these things just end up being just a lack of awareness of what may be available. So opportunities and recommendations. Now here is, again, these are from partners mainly, and some best practices that we've seen in other states. But again, this is all really generated from partner discussions and partner feedback. So this is coming directly from community members. So Kentucky is working to increase Medicaid rates overall, but partners underscored the need to continue to think creatively. How do we further support the workforce through funding and incentives? There are loan repayment programs, but there was cited a need to maybe evaluate the effectiveness of those programs. Other recommendations included career assistance support, home buying programs, childcare stipends, signing bonuses, postgraduate support, things like reducing the cost of licensure, cross-licensure, all things that may be helpful to recruit and retain members of the workforce. They also mentioned coverage parity and the need to ensure parity in reimbursement. The minimum wage also came up as far as the healthcare workforce, specifically to retain the workforce. There were a lot of comparisons across, working within a community-based organization to working at Starbucks or working at McDonald's, and how am I going to keep my people here if they can make more money over there? So that came up as far as a recommendation for how to raise the minimum wage. Addressing provider workforce shortages is a key priority, and supporting the workforce is a key priority for Kentucky. Partners cited the need not only to increase the workforce, but to potentially expand the reach of existing professionals. And we've mentioned peer supports, but also community health workers and even occupational therapists as including as paraprofessionals. And as the utilization of paraprofessionals expands and continues, they must be supported by professional organizations, standards, and oversight to avoid overutilization, inappropriate utilization, and burnout. In that same context, partners talked about warm lines and expanding warm lines to offer behavioral health support outside of emergency crisis situations as a better way to utilize paraprofessionals while offering a valuable service to the community. Telehealth, of course, was discussed a lot. Partners underscored the need to continue to support broadband efforts and Medicaid expansion to continue to increase access to telehealth, especially in the rural areas, but also in schools. We talked about Project ECHO, which is, there are a couple of ECHO sites in the states, which is a professional mentorship program that can bolster capacity of local providers. Creating a statewide training program as a public-private consortium could help build capacity of professionals across the continuum and ensure that existing resources are fully maximized. And this could include local academic institutions. How do we increase the pipeline and secure the pipeline of professionals? This infrastructure could also be used to ensure providers are up to date on billing practices and appropriate billing and correct billing and any billing changes and things like that. Integrated care models are, of course, widely cited as effective strategy to bolster behavioral health care and access. And to implement integrated care on a statewide level, partners discussed a need to increase collaboration and communication between existing committees, work groups, and other governance structures to create a singular vision that everyone is rowing towards and working towards. BDID, we know, is beginning to examine and evaluate what integrated care models are in practice, but again, having a statewide vision can help further that expansion. And of course, there's a lot of federal funding to support any of those efforts. Addressing known gaps in care, of course, that are identified, including reviewing funding, policies, legislation that either are needed to support addressing those gaps or hinder expansion of those needed services was also discussed. And finally, continuing the focus on health disparities and health-related social needs. A lot of partners talked about the importance of community-based organizations, including the CCBHC, CMHCs, as the local trusted resources to serve the very needs of their local communities. They know the communities best. Partners talked about, again, that need for screening for health-related social needs. When asked if they conducted those assessments in the survey, it was 18.4% of behavioral health providers said they didn't do an assessment, and 21.6% said they didn't know if they did that assessment. PCPs were more likely, about 34% said that they either conducted a screening as needed or on every visit. But again, there's still that concern of, if I find an issue, I need to know how to help them. I need to know where to refer them if I find that there is something that they need help with. And there is the SDOH Medicaid Data Project, which is really cool, which helps to address that concern by linking the assessment project to KaiNet for ease of referrals. So that expansion of that and ongoing support of bringing that to the community would help to address that need. Other opportunities, of course, include continuing to support health insurance enrollment, partnering with community-based and local organization, expanding the connectors, maybe bringing them to schools, and increasing access to free, low-cost, supported training on cultural competency, and standardization of an equitable screening process. Couple more things. Yeah, managed care participation was widely cited as a challenge, again, to work with all of the various policies and procedures and looking at how to standardize performance measures and ease the burden, the administrative burden across the board was talked about a lot. And yeah, overall, as you all know, there's a lot of great initiatives and programs designed to improve the behavioral system of care overall. So looking at how do you evaluate, what are the key metrics, and how do you regularly report, coming up with that way to continuously evaluate the behavioral healthcare continuum as you rapidly expand is also something that's important to consider. So key takeaways and some next steps. So I think the first thing that it's important to really underscore is that Kentucky is not alone in these challenges, right? These are national challenges that other states are also working through to improve their behavioral health continuum of care. And they provide us examples and some lessons learned as well. Kentucky also benefits from really dedicated partners, and there's just such a high level of commitment across all of those that touch the behavioral health care system of care and behavioral health workforce. And by leveraging that dedication, you guys are going to continue to move things forward and develop that roadmap and that vision and strategies and actual actionable steps to achieve that. So yeah, I know Dr. Hoffman had said this early on, but this was just a really super high level overview of what's included in the behavioral health needs assessment. So there are 5 documents that you see here. These documents go far more in depth than we were able to get through today, of course. All of these documents were reviewed for a long period by representatives at DMS and BDID, and they are with they're with Dr. Hoffman now to finalize. And I think after signing off, we should be able to share them with you all to do a real deep dive. And I know Dr. Hoffman mentioned again, this is a snapshot in time where we're as good as the data we received and as good as the information that we were provided, but it's a good starting point. It's a solid starting point. And these will be living documents. And as you review them, you look at the data, you look what came in through partner engagement, and it's a place from which to start. It's a place to build from. And there are many initiatives, obviously, now that are underway that will be important to continue to add to this the statewide needs assessment. It's a good starting point, and it's a solid referral source as we're looking to develop further strategies to expand the behavioral health system of care. I think that is it. I know if we'll be sending the presentation around, I don't know exactly, Dr. Hoffman, I don't know
I was just
when.
going to say, since we've got
Yeah.
so many questions today, and Amy, mark this draft before we send it back out. So because it is still a draft, we'll mark it draft. And then Aaron, I think it might be better since I started just to say to send us the questions, but I want to make sure that we keep them all together for this TAC. Do you think it would be better if we just have folks to send you the questions, or Dr. Schuster, could you compile the questions or suggestions on the PowerPoint and send them to us later?
Yeah, I think we can do that.
I think it might be better.
I think we
together.
made some notes here, and then we have a mechanism for people to send those questions.
Yeah, I wanted to say, Dr. Schuster, just so you know, we did have, I should have mentioned it, we did have someone from our team on the line that was taking detailed notes on the questions as well. So we also have them, but send anything that you have as well. I should have mentioned. Thank you.
Yeah, that's good. It would be helpful to have this PowerPoint as a reminder to us of what questions we had.
Yeah, we'll go ahead and send it out.
Market draft.
Yeah,
and
that's what
I would suggest that you put the time frame on there on the PowerPoint, the time frame for the study.
Yeah, and Amy, we'll just consider this number 1, and then we'll have revised. Let's just keep it straight, because folks will get all confused. If we end up with 3 or 4 of them.
Yeah, let's call this version 1.
Version 1.
Yeah.
Maybe put the date on it as well.
That's fine.
Yeah, it actually has the date. I think on the first slide, it has today's date on it. So, yeah, you know, this is a great start. And I think anytime that we're faced with data, it raises tons of questions. And I think you got some good ones, and you had some, you had some good precipitators of the questions. So we appreciate that. And I think I think we're all dedicated to really getting a good feel and trying to figure out what the variables are. And it's tremendously complex. So I appreciate, the presentation. I think it was a good idea to do it. Appreciate your hanging in there with us, Amy, and Martin as well, to try to answer these questions. And, this little BH-TAC did a Medicaid study on the issue of targeted case management. And I think those of us on that little work group, working with the DMS staff and then with the UK staff, realized the complexity of looking at Medicaid data and trying to ask the right questions and get the right answers and get the right data in the right place and so forth. And that was a tiny piece compared to what you're offering here. So I think you have some idea about what our questions are, but we do appreciate that. And we will follow up with you.
Right. Thank you all. Thank you, Dr. Schuster. Thank you all for your questions. Much appreciated.
It's good work, Amy. Thank you.
Thank you.
Thank you. Good to see you.
Thank you very much. And thank you, Leslie, for bringing that forward. I had an item on the agenda about following up on the audits, but we really kind of talked about that around the response to the recommendations. And also we're looking at what's the track that's going forward on looking at prior authorization. So, and I think Jennifer Dudinsky was on, but had to leave. And she's our resident guru on audits and so forth. So I'm going to move on and we'll come back to that next meeting. Our favorite thing, Leslie, and of course I'm nervous as hell because I don't think CMS signed off on our 1915 spa, right?
Yeah, well, we did, and I think Ann's on, she's gonna give you an update as well, but we did get submitted back to them the day before inauguration.
Friday, January 17th, we officially submitted and put it back on the clock. So as of today, we don't have official CMS approval. And our timeline is really contingent upon that approval. I do want to say that the implementation date it still remains 7/1/25. It's what we have in the application to CMS. Our goal is to begin training and onboarding providers 2 to 3 months in advance of the go live date of RISE. Of course, system changes for provider enrollment, billing, integration of the functional assessment tool, and key factors associated with implementation are all built into that. And then I do want to finally say that regulations are drafted and under internal review, and DMS anticipates filing with LRC in February. And I've opened the floor up to my colleagues in Medicaid if they want to add anything to the conversation.
Just that, I just would also just say that internally we're like working on a lot of things in the background. Of course, there's tons of system changes and contracts and regulations and all those kinds of things that are going on in the background that folks forget about sometimes. So we're working diligently to get this going. We do support, Ann and I both in the two departments support this state plan amendment to get approved, and we're trying to work as quickly as we can.
And with things in a bit of an uproar in DC, we really don't know. I guess there will be some massive changes. I understand that HHS is, all their travel has been removed, and I don't know what all's going on. So I'm sure that we'll have to wait and see.
We're still working. We haven't. We're not sitting, on our hands. We're working as if we're getting approval. So we continue
Good.
to have regular meetings. Myers and Stauffer is also helping to keep us on track. So, we're still working on it.
And I would mention too that we got acknowledgement that they did receive our application back. But if we don't hear from them in a couple of days, I told Jody to give them to at least Friday, because we sent it on a Friday and Monday was a holiday. So I told her to give them to Friday, because I'm sure it's like you said, Dr. Schuster, it's probably a crazy place right now, right?
Yeah.
To get your work done there.
Yeah, that would be great. All right. Well, thank you very much. I'm glad that you all are still, and we need this badly, as you know, so we're going to keep on keeping on, as they say. Is there any status update on the reentry waiver?
I was just going to give you a couple of updates, Dr. Schuster, and if I don't want to take too much more time, and you might know some of this already. You're aware that we submitted our monitoring plan on November the 26th. We had a public forum that we conducted December the 12th. So if anybody wonders if that's on the website, we're hoping, I just checked on it, we're hoping to have that posted probably sooner than later, but before the next behavioral health TAC. The reinvestment plan and evaluation design that was submitted on time. Everything we've done has been on the day or a day or two earlier. We've tried to make sure that we get those in. Documents submitted to CMS are, not typically published until we get back and forth with our back and forth conversations completed with CMS in case they want us to change anything. with January 1 starting, our whole escalation and focus has kind of been on our implementation plan for the first of 2025. As you might be aware, our Kentucky implementation go live of the Consolidated Appropriations Act. I think we're the first state that did this, went live January 1. It doesn't meet all the requirements for the reentry piece of, or the full acknowledgement of the Consolidated Appropriations Act. So we're still working with those things so that the CAA will align more with the 1115 efforts in 2025, and some efforts in our last quarter of 2024 was starting to advance that. So we're a lot very far ahead of the other states. I haven't heard any different. I was told by CMS that we were the first state to send in their state plan amendment for the Consolidated Appropriations Act. And I know a lot of that just sounds like fluff, but if you can imagine all the stuff that we've got going on, we're ahead of the game on this one, and we're trying very hard. And we meet with Steve Shannon and the Returning to Society community folks on a regular basis and trying to keep everybody apprised, very transparent. We want you to know what's going on. Our dates for the next ACRES, which is our Kentucky Advisory and Community Collaboration, I think that's coming up soon in February. I would also mention that we are very proud and pleased that in the midst of all this, we were able to get the Consolidated Appropriations Act grant approved. It's a 4-year grant, and it's for approximately $5 million. Our first year is around 1.6, and you'll probably see more of that from us, more information about that later. It looks like to me what they're going to do on this grant, not just giving you the whole amount or the approval for the whole amount. They gave us the first year, and then each year we will ask for the amount that we had originally asked for, plus any a reconciliation from unused funds from the previous year. So it actually could mean that our numbers might move around a tad. So we're very pleased with that. That is actually has some embedded funds to assist with our jails. We are just starting to work with our jails as well as giving some funds directly to Department of Corrections and our sister agencies. They're actually outside of our cabinet, but at this point, I feel like they're totally our sister agencies, giving money to DOJ and DOC for alignment, auditing, making sure they're in compliance and those kinds of things. So more to come on that grant. We really just got the award. Gosh, just recently I sent that out for everybody. So more to come. I think that's all I have for you right now for reentry and CAA. We're busy at work and doing a lot of these processes manually right now for CAA to ensure that we got to have a Kentucky go live January 1.
Yeah, I think you sent a notice out about that grant. I'm really glad to hear that you're starting to talk to the jails.
Yes,
Leslie, because we've really so many of our state prisoners are in those local jails, and they vary tremendously. I know that's a much harder task than dealing with the Department of Corrections and having the prisons.
It is,
you
yes.
know, that's much more contained, but really glad to hear that.
Angela started last year working with the Jailers Association. We've had several meetings with them, and just moving forward with how to best, because we don't have a lot of experience. We're trying to figure out how to best address those each individual jail, and some of them are very rural, and and all are publicly elected. They're a little bit different in each county. So yeah, that's it.
Right. Yeah. Thank you. Any other questions for Leslie on the 1915I or on the reentry from any of the folks? Okay, how about the 1915C waiting list, Leslie?
Just a second. Home and community-based waiver, so that's our HCBS waiver, 2,819. Michelle P. waiver is 9,409. And supports for community living is 3,531.
And no waiting list for either of the ABI waivers?
No. Let me double checking. No. And this report was ran actually, Dr. Schuster, on the 17th. It's the last report I had.
Okay, thank you. I don't have the numbers in my head from the last time you reported in November. I'll have to go back and look. You don't have that.
I don't have it right in front of me. They're,
Yeah.
they're a little fluid, you know that. And actually, if I, have checked it the same day, 20 minutes later, it's different. So
Yeah, oh, I'm sure that's true. But it continues to hover. Actually, that looks high to me. So that's 3,000, 12,000, 15,000. That looks more like 16,000. I think that's high.
wait list, let's see. Let me just double check. That should be around 9, 10, 11, 12, 13, 14, 15. Yeah, I'll double check that. I think the last time I reported to you was around 13,900.
Yeah, that's what I was remembering.
I do have that. I think it's
But
around
see,
13,000.
that might be the unduplicated number.
Oh, okay. So
Not sure what report, what.
Yeah,
report
Misty
that-
has in there, unduplicated is 13,992.
Thank you. Thank you, Misty. We've been trying to do better at being transparent to let you all know that, we've got a lot of folks that are multiple wait list and
Yeah.
a high amount of folks who receive services already in one waiver, but on another waiting list. And then a high percentage, of course, that do have eligibility for state plan services if needed.
So the unduplicated number is just counting them one time for a waiver wait list and not on multiple waiver wait lists. Doesn't count or doesn't take into account any of the already getting other Medicaid services.
That's correct.
Yeah. Okay. Thank you. And do you have a wait time for the PDS services? I'm still hearing from people about the
Dr. Schuster, I did some, I was going to say you can appreciate this, my back of the napkin math. No, I'm just teasing, but we tried to pull this together for you. So, I mean, this is rough and don't hold me to it, right? Because we've got to this is just preliminary and we need to go back and do some more, some deep diving for you. But it looks like for HCBS waiver, it looks like we've got about 2% at less than 3 years. 22% at less than, I'm sorry, the first one was 3 years. Did I say that? And 22% less than 2 years and 76% at less than 1 year. And I just did some quick averages a few minutes ago or before this call. And then, so that's the HCB waiver. For the Michelle P waiver, I've got 26% at less than 3 years. 50% less than 2 years, and 24% is less than 1 year. And SCL we just had, it was easier to get to. It was 8 months or less. Everybody is 8 months or less.
Okay.
So we can do, if you want me to just let me know how you want that to look, and we can do a better, deeper dive and break that out more for you going forward.
Sheila, is the percentage that you said, Dr. Hoffman, what about ABI? Because I know there are people waiting for ABI.
Oh, I'm
PDS
sorry.
service.
I've got, now this is what I've got in my list that was given to me today was ABI 1% less than 2 years. I think that's what I've got. So again, Mary, let us do a deeper dive on that one as well. I didn't have much. I don't have 0 on ABI LTC.
Now, are these people who are getting PDS in their wait time or people who are waiting aren't accessing services yet?
Misty, correct me if I'm wrong. These are people that are on the active waiting list.
For PDS?
Yes, for PDS.
So they're not getting waiver services now, or they're not getting, okay.
Now, don't forget, folks do have, and I know we've got waiting lists. They do have option for traditional, but many wait. Right. That's what they're looking for.
Yeah, let's, I kind of like the less than 3 years, less than 2 years, because I think what you've given us before is a kind of average
Yeah, it's hard to.
months or something, and it was really hard to kind of
It
understand
is.
that.
I just before this call, I thought, well, I'll just maybe if I can put them into categories. But the best thing that I saw was, of course, a large amount, 76% less than a year on HCB, and Michelle P. About 25% less than a year. I was trying to see where we were, and of course, SCO is already less than a year. So we can average those together into one as well for you.
Leslie, what is it a percentage of? Is it
the total number that we've got on the wait list that we're aware of? And
so you have the population of people that are waiting for PDS, and of those, 76% have been waiting less than a year.
That's correct. And again, I want to double check those numbers and meet with our sister agency as well.
I'm just trying to wrap my head around, is that the best way for us to track this? You know, I think I also want the raw numbers.
Okay.
How many people is that 2% that have been waiting? You know,
and again, please don't, like I said, I did some really quick math there. So
right.
I might be off just a percentage or two.
Yeah, no, but it gives us a ballpark. But don't you think, Mary, it would be helpful to actually those numbers
I was just
are?
getting ready to echo saying, I think numbers of people, because you're saying you don't have a waiting list for ABI, but you have a 1% waiting for PDS. So I'm trying to wrap my head around that. So yes, I think numbers of individuals or number of slots, however way you all want to characterize it. But yes, I think the percentages are nice, but I don't think that really tells us the story.
Okay. Misty, are you on? Is it one person in ABI? Is that one person is less than 2 years for PDS?
Yes, currently on the active wait list, we have one person
Mary,
for
it's
ABI
not 1%.
only.
Okay, it's not 1%. I've got one person on that one.
Okay.
So
let's do both the percentage and the raw number, if that's possible.
And Misty, are you on? Can you help me with that on that for the next time?
Absolutely. Would you like me to read through what?
And do both ABIs, because I'm questioning that one person because of just for what I was told by one of the comp cares. I'm not saying that's not accurate. Maybe that person already got the services and I wasn't aware, but yeah, I like to know it broken out for both ABIs.
I would say, the data is only as good as we get. So if somebody's on the list and then they are given PDS, but we're not notified for a long time until we're going back through checking our list, then, it's possible,
Yeah, that's a good point, Alicia. Thank you.
People don't always follow up with us when they,
when they get it. So, and reconciling the anecdotal information with the numbers that you actually get, we know that there's some slippage, but it's just a way of keeping track of it, because I think Mary's like me, I keep hearing from people about the long waits for PDS, and I'm trying to figure out, and it's in Louisville, so there ought to be providers there.
Dr. Schuster, I'm not sure, but if you're hearing from the Michelle P. waiver folks, that one, it has a larger percentage that have been waiting longer. So I'm just going to mention that.
Yeah, no, I think it is Michelle
That's
P.
probably what you're hearing.
Yeah. And Michelle P. is our problem child in terms of just look at the number of people just on the waiting list to get into Michelle P.
Yes, at least 50%, around 50%. Yeah.
Yeah, so many of those are kids, right?
Yeah.
And if we ever get our
about 76% or less than a year, so that you're probably not hearing from them as much.
Yeah.
And SCL's moving fairly quickly. I know 8 months is still a long time, but considering where we are, I think that one's moving fairly quickly.
Yeah. All right. Well, thank you. I think if we keep working at it, we'll come up with the back of the napkin, as they say, but it's helpful to have those numbers. And thank you, Misty, for your input as well. Any update on the ABI waiver in terms of access to therapy services?
So as of today, we're still on hold, and I've mentioned this to you all in other calls, that I will make sure that we have ample notification and communication out to folks. So still on hold right now.
Dr. Hoffman's okay if I go, Sheila?
Yeah.
Okay, I received a telephone call from a doctor. He is stating to me that he has a new client that is receiving, or who had just received their allocation for the ABI waiver. And I don't remember if he told me long-term or the rehab, but I think he said long-term. But that he was told because his client was new that he would automatically have to go into the state plan, but that if he had been prior already on the ABI, then he didn't have to go into the state plan.
Yeah.
Is that true?
So I'm looking, there was a communication that came out. This was like 2 waiver amendments ago. CMS started asking, you know, why were the therapies still in there? We were understanding that you'd removed them, and there was some communication, and I have a copy of it, but I'm looking. There was 2 communications, I believe, at least. I'm lying. One communication I think that came out while Pam was still here that said if it's a new member who has never received services in the past, that they would go through state plan. But if it is existing member, we're on hold for any changes. And Alicia, am I correct? I'm looking for that letter right now. I've got a copy of it somewhere.
Yes, you are correct.
Thank you. So that's probably what's going on, Mary. And Alicia, do you remember a time frame? Was it May, April? April. I think it was April, Mary.
Be honest, I don't know. I can try to go over.
I think it's April, and I've got it here somewhere, but I'll try to find it again. So yeah, so
I directed the doctor to you guys, but he's very, and these are his words, he's very depressed. He has somebody that's newly injured and would benefit from the therapies, but not able, and these again his words, not mine, and I did direct him to you and to Lisa Lee, but I think there's just a lot of, I don't know how exactly to say, there's just a lot of pessimism around the ABI waiver and the therapies. It's great that you're still keeping those ones in there, but then, you know, for newly injured folks, that really is kind of arbitrary, because then they're not able to access the more skilled therapies that you would get from some of the other individuals. So anyway, that's just a keynote. Those are his words. I did direct him to you and to Commissioner Lee, but just to say there's still a lot of pessimism around the therapies.
Okay. And Mary, I know you don't want to hear this, but if the individual needs the service through the state plan and they can show medical necessity, they should be able to continue services. I know that's not helping you with the situation of a specific ABI provider, unless that ABI provider also has, you know, a strict Medicaid number where they can bill, which a lot of our providers do. A large percentage, I think, do have those numbers. But I know there's you know, I know there's unhappiness related to rates and things like that.
Yeah.
If we had,
I've asked him to write something up, and I'm hoping he will, but he is a doctor, and he has served our clientele for many, many years. So I'm hoping that he will put something in writing to me, and then I will then forward to you if he's not already contacted you.
Okay, that's fine. Thank you.
All right. Thank you, Mary and Leslie. Next is the survey results from the survey that was sent out about changes to the MAC and the BAC. And the deadline was December 31st, I think. So is anybody on from Medicaid that can respond to this?
I believe Veronica is still working on constructing answers from all the feedback. From my understanding, I believe we got a lot of feedback that they're working on getting compiled into one like response type document.
Okay. She sent me a note telling me that Commissioner Lee was on vacation and that Leslie would be covering the Jordan today, but she did not mention the survey.
I don't
So-
have any additional information, sorry, Dr. Schuster, on the survey, but we can follow up on that.
Well, and it's on the MAC agenda too, and that's tomorrow, so it would be helpful to, you know, she told me in the note to me that they are not prepared to talk about the legislation itself because it still is not completed. You know, it still's under wraps, but I thought we would at least get some feedback on the survey. So if you might ask her for the.
I'll ask
meeting
Veronica
tomorrow.
if if Veronica plans to.
Thank you. Are there any recommendations to the MAC from the TAC? I think that we are not ready to make a response to the DMS response to our last recommendation, so I don't think we have anything there. Anybody else have anything?
I don't think so.
Okay, any other voting members have any recommendations they want to put out?
Not at this very moment.
Okay. All right. In the March meeting, we will go back to the issue about approvals of residential SUD treatment services. And I think that we did not settle. Is this right, Aaron? We talked in November about what we would ask the MCOs to report on, but I don't think we ever actually finalized it.
That was for the MAC.
No, that was the TAC here.
The closing of the care gaps, that was on the MAC agenda.
Yeah, no, this is about the approvals of residential SUD treatment services.
Oh, my apologies. No, I do not believe we made that formal request in the last meeting.
All right, so I'll get back with Bart and Mandy. Had brought that issue forward and we had a discussion. I'll have to look at the minutes from the November meeting and we'll get that out. I did have a new business item that came from Dr. Rayapati, who would like to have a discussion of the 8-unit cap on peer support specialty services. That's H0038. And he says, given the overwhelming data showing the benefits of peer support services, do the MCOs have any guidance on how to continue providing them with this 8-unit cap? So I think what we will do is to circulate that as a agenda item in March and ask the MCOs to be prepared to respond to that. Can you make a note of that also, Aaron?
Yes, will do.
All right, thank you. Any formulary issues? That's the other thing we always put under old business. Oh, what was that code again? It was H0038, which I think is the code for the peer support specialty services. And I don't know how new or recent or whatever that 8-unit cap is. Do you know, Steve? Do you remember that?
Not.
Yeah. I don't
It was
know whether
capped in January, as of January 1st.
Okay.
The old cap was 20 units.
Oh, okay. So it's a decrease from 20 units to 8 units as a cap?
Yeah, it was.
Yes.
It was in a provider letter. I'm trying to find it so I can send it to you.
Okay.
It also reduced the maximum lifetime cap per client to 200 units.
Right. I remember that.
Not sure if there was a cap on that before. So essentially 5 weeks of of treatment is all that is approved now.
Wow. Okay.
Yeah,
I mean, I don't think-
that would be a great issue for our next meeting because I think those are arbitrary caps that aren't necessarily tied to assessment and treatment.
Right.
Yeah, I'm sorry, who's Chris that gave us that information?
I'm with Oliver Winston with Dr. Ratpotty's office.
Oh, okay, thank you, Chris. All
It was
right.
Bart chiming in on the provider letter, Sheila. Sorry.
Yeah, I know, you come up with your full name, I know who Chris was, but I just,
Okay, gotcha.
I didn't know if he was a interloper from outer space or what, so he seemed very knowledgeable, and I'm glad you gave us that information, Chris, I didn't mean to.
Madam Speaker, can I ask a question?
Yes.
This is Chirag Patel from WellCare. We represent the MCO. We'd love to give a retort and a response. Part of our response, can we bring the evidence-based guidelines related to or not existing for these particular services so we can have a discussion rooted in science and evidence? Because there are some bodies of literature out there discussing that. Maybe we could use that as grounding information so we're all working from a same set of understanding around those particular services. Because while it does feel like a huge delta between 20 and 8, there was a reason why DMS did that, and we'd like to articulate maybe some of the rationale why we supported that.
We're always happy to see real data and science, Dr. Patel. And if you would like to send me any of that in advance, I'm happy to circulate that so people have a chance to dive into it.
Yeah, my team and I will confer, but we'll make sure that we involve the other MCOs as equal stakeholders in that discussion and that response. Thank you so much.
Yeah, and I agree, Sheila. Getting it beforehand would really help.
Yeah, because otherwise everybody's hearing this kind of like the presentation that we had on the needs assessment, and then everybody's kind of trying to take in the information. But if you have data, Dr. Patel, and a rationale, then let's see it. Send it to us in advance.
Thank you.
Thank you. So any formulary issues? Val, I usually count on you. Kathy Dobbins is asking went from 20 to 8 units with what frequency? I don't know yet. Per day, okay. Per day, Kathy.
Thank you. I've got a cold or bronchitis or something, so I'm off camera.
Okay, thank you. Val, anything that you're hearing from consumers?
No.
Medications, okay. All right, our next MAC meeting is tomorrow. So get up bright and early at 9:30 Eastern time and come to the MAC meeting.
Hey, Sheila.
Yeah.
This is Barry. I think Darren was on here. We were going to talk about the IOP issue again.
Oh, okay.
That's still not been resolved. I'm not sure where we need to take this from.
Our ask is that that the state open the regulation up for discussion, because a retroactive perspective or interpretation of this is resulted in just a mass recoupments without providers' ability to go back and rebuild claims due to timely filing.
And just to add on to the PHP IOP, we're still waiting on guidance from DMS on the use of telehealth for IOP and PHP. This is Nina Eisner.
I see you.
Yeah, I should have included you, Nina, as well. Darren and Nina.
That's okay.
Tell me again about the telehealth issue.
We're still trying to get resolution from an October of 23 statement from DMS that telehealth was no longer an option for PHP IOP. We did get follow-up from the commissioner I don't have the dates in front of me, but back in the winter, that CMS was going to allow telehealth for PHP IOP as long as medical necessity criteria were met and appropriately clinically provided. But providers across the spectrum of care have been reluctant to re-implement that until we have a provider notice that overrides the communication from October of 23. So we're still waiting on that.
And you have raised that at the MAC meeting too, Nina, right?
I have MAC,
Yeah.
TAC, and
I know,
spoken.
I was trying to remember because I thought we had a discussion about it and I thought there was some resolution. No?
No, we've a couple of the hospital providers and KHA have drafted a draft provider notice and given it to DMS, just based on the communication that we had received. So we thought it would be a slam dunk, but we're
Hi,
still waiting.
Nina. It's Angela Sparrow. Just
Hey,
quick
Angela.
update.
Hi.
Hey. So a provider letter has been drafted, and it's under review. So there is a draft, and we'll take it back as a follow-up and resolution.
Thank you, Angela. I'm going to ask the same question tomorrow on the MAC, just FYI.
Okay. All right. We'll be
Poking that bear.
prepared with an update. Thanks. That's all right.
All right. I knew we had
Okay.
had this
Thank
discussion
you.
before at the MAC, so.
Yes. Thank
all
you
right,
so much.
So we need to be sure that that gets resolved. We have the IOP billing issue that Barry and Darren and Nina, you were helping them with that. And that's the issue that if it has to do with the calendar and counting the days. And
It's if
whether
there aren't,
nurses-
it's if there must be at least 3 days of service delivered within a rolling 7 days,
Yeah.
calendar days. Otherwise, none of the care is paid for.
And monies have been recouped from years ago without the ability to go back and then bill those services as individual
Yeah.
services.
There's some hospitals who are experiencing retro recoupments back to 22.
And we just want some open discussion about it. That's what we're
Yes,
asking
please. Yes, please.
for. Yes,
Yeah.
please.
Yeah.
Yes, please. Thanks, Darren.
All right.
And Darren, who's recouping? Medicaid or the MCOs?
The MCOs.
The MCOs.
And then we can't bill. We have no court
Right.
to
Timely filing,
rebill
right.
anything, which
Right.
the services rendered were not. Okay, I'm gonna stop. Just please put it on
Yeah.
the agenda for next time.
Correct.
But
Thank
I'll
you.
finish it for you, Darren. The services rendered
Thank you.
were in compliance with the existing regulation.
Unless you reinterpret the regulation
Right.
years later.
Yeah.
Exactly.
Gotcha.
Visionism.
It's a per diem service, by the way, not a weekly service. It's a per diem payment.
Correct.
Yeah, I remember when you all first brought that up and I thought, how does that make any sense? So you do the
Mhm.
service, I mean, the service is provided, the service should be paid for, the patient received it. Okay,
Yeah, just to
So-
chime in on this, I've heard from providers, non-hospital, because I know the folks talking about it are hospital, but I've heard from other just ILP providers with some of the same issues. So it's beyond just hospital providers.
yeah. Okay, so we've got a growing,
Yeah, that's what.
I'm gonna have
Darren
to
and I
go
were
to a
talking about.
second page on the agenda, folks. This is a bad idea.
Sorry, Larry.
All right, thank you all. You know, this has been lively discussion considering that this was a rescheduled meeting, and I appreciate you all and your participation with a rescheduled meeting. So we will see some of you at least at the MAC meeting tomorrow, and stay warm, and otherwise we'll see you in March. Thank you all very much.
Thanks, Sheila.
Meeting is
Yeah.
adjourned.
Thank you.
Okay.
Thank you.
Bye-bye. Yeah.